So, hello everyone. I'm Dr. Omkar Sangita Dilipra Sonone from Team Fmge, and once again, I'm back with the session for Fmge June 2022 recall questions. So here also today we have around 55 to 60 questions that we'll discuss in today's session. And I hope all of you have watched the previous two videos as well. Apart from this, definitely I would like to once again highlight that we are already starting the batches for December 2022 session of FMGE. And most of the batches, like one or two batches have begun already. The another batches will be starting soon. So if you wish to join AFMG, please do contact as soon as possible. So yeah, with this, I begin the session for today. So let's discuss about few more questions about of the recall. And I hope all of you are chilled, relaxing, okay, till the results. All the very best for your results. Till then, let's go with your questions. Question number 126 now. A child presents with complaints of blackish discoloration around the eyes and ears due to deposition of a blackish pigment. On examination, the urine turns black on standing. Which among the following enzyme is deficient? So this was a classical case we have discussed in biochemistry and even in pediatrics multiple times. So I don't think so you would have any issue. This is the inborn error of metabolism. Here there is some enzyme deficiency due to which the child is presenting to you with some blackish discoloration, usually around the skin of the eyes or usually on the ear cartilage. And this is blackish discoloration of the skin or the cartilage is actually called as ochronosis, right? This phenomena is called as ochronosis that we have discussed. Along with that, they have also given on examination the urine turns black on standing. That means usually when the child urinates, it is yellow in color. But when it is exposed to air, it will turn black on standing. This is a classical funda for your diagnosis. That is what is known as alkaptonuria. Okay, here the disease is nothing but alkaptonuria. It is an inborn error of metabolism. And as we know, alkaptonuria mein which enzyme is deficient? It is option A, homogentisate oxidase. As I told you, this time they gave the older name homogentisate oxidase, but sometimes they can even give you the new name, that is homogentisate dioxygenase. Okay, the new name for homogentisate oxidase is homogentisate dioxygenase. Okay, so be sure with this name as well. Apart from this, we know the branch chain keto acid decarboxylase. Branch chain keto acid decarboxylase is an enzyme which is deficient in maple syrup urine disease. It is deficient in maple syrup urine disease, and there the urine will have maple syrup like odor or burnt sugar like odor. Okay, that is important that you need to know. Whereas tyrosine hydroxylase usually is an enzyme deficient in tyrosinemias. Okay, whereas important condition is phenylketonuria, in which the enzyme deficient is known as phenylalanine hydroxylase. It is known as phenylalanine hydroxylase. There the urine turns green. Okay, there the urine turns green, usually with the help of a ferric chloride test. Okay, that is what is phenylketonuria. Moving further now, question number 127, guys. Which among the following will inhibit the complex 4 of electron transport chain? So a commonly repeated question, repeated recently in NEET PG, as we have discussed in PYQ session also. One of the favorite question of examiners from biochemistry, and a straightforward, pretty straightforward question. Which among the following will inhibit complex 4 of ETC? So it is a straightforward answer, that is option C. Cyanide inhibits the complex 4 of electron transport chain. Apart from cyanide, definitely carbon monoxide also inhibits. Carbon monoxide, not dioxide. Okay, so carbon monoxide also inhibits the complex 4 of ETC. Okay, apart from that, definitely H2S, that is hydrogen sulfide, can also inhibit the complex 4 of ETC. Whereas as we know, one जिनमें आता है, that is phenobarbital or rotenone. Okay, one आता है, that means they will inhibit the complex 1 of ETC. They will inhibit the complex 1 of ETC. No issues with this, anybody? Please remember this. Moving further now, question number 128. A patient was having swelling in the metatarsophalangeal joint. So it was either metacarpophalangeal or the metatarsophalangeal joints of foot. Okay, whatever it is, as we know, it is a very easy diagnosis. Okay, a patient was having swelling in the metatarsophalangeal joints and the serum uric acid levels were elevated. So if serum uric acid levels are elevated, that is what is called as hyperuricemia. Okay, and as we know, whenever there is hyperuricemia or elevated levels of uric acid, this uric acid crystals will deposit usually in the joints. Okay, and the most common joints involved are usually the metatarsophalangeal or the metacarpophalangeal joint. Out of that, the most common one, okay, the most common one out of all is the first metatarsophalangeal joint, also called as your great toe. Okay, now the diagnosis will become easier. So here, definitely elevated uric acid levels, there is pain and inflammation or swelling at the level of metatarsophalangeal joints. Okay, so here the diagnosis is definitely gout, right? Here the diagnosis is gout. The doctor prescribed the medicine for the same. The medicine will act by inhibiting which of the following enzymes. So as I've discussed, this is a Sarkari question multiple times in pharma, almost everywhere in medicine, everywhere we used to come across this question. All of you were quite sure of this. Okay, so a patient of gout is started. Chronic gout ke liye drug of choice, as we discussed yesterday also, the drug of choice for chronic gout is allopurinol. Okay, so drug of choice for chronic gout is allopurinol. And if a doctor is prescribing some medication, that would be allopurinol. And this allopurinol will inhibit which enzyme? So as we know, allopurinol will inhibit the rate limiting enzyme of purine metabolism or purine breakdown. Okay, so please remember the rate limiting enzyme of purine metabolism is known as xanthine oxidase, and allopurinol will block or inhibit this enzyme known as xanthine oxidase. So allopurinol is a xanthine oxidase inhibitor. This is a commonly repeated question. I hope so nobody of you have made mistakes in this. As we know, adenosine deaminase, ye bhi discuss kar liya tha humne. This enzyme is usually deficient in a condition called as KID. Okay, this enzyme is deficient. This was the last time question in December. This enzyme is deficient in condition known as KID, severe combined immunodeficiency syndrome. Whereas HGPRT, we know HGPRT is hypoxanthine guanine phosphoribosyl transferase. HGPRT enzyme is usually deficient. Complete deficiency is seen in Lesch-Nyhan syndrome, whereas partial deficiency is seen in Kelly-Sigmiller syndrome. No issues with this, anybody? Here also the patient might have gout, but along with gout and Lesch-Nyhan, the patient will also have features of self-mutilation or self-harm when the patient will bite himself. Okay, so that is the case. Moving further now, question number 129. In fasting state, secretion of glucagon aims to produce glucose mainly by which of the following mechanisms? ठीक है? So as we have discussed about the basic funda, पहला slide जो था हमारा biochem chanting का, definitely we have made a difference between insulin and glucagon. As we know, insulin comes on one side, whereas all the other hormones like glucagon, cortisol, catecholamines are on the other side of the table, right? And as we know, insulin is usually anabolic hormone, so it is usually active in fed state. But as we know, glucagon is a catabolic hormone, and therefore it is active in either fasting state, starvation state, or in cases of diabetes mellitus, right? So in these three conditions, we have glucagon which is active, right? We have discussed everything that usually insulin activated enzymes or pathways will be active in dephosphorylated state, whereas those activated by glucagon will be active in phosphorylated state, right? ये सब discuss कर लिया था. Insulin will decrease cyclic AMP levels, whereas glucagon will increase cyclic AMP levels. All of this was discussed. Along with that, I told you whenever glucagon is in fasting or starvation state, usually it will activate all the catabolic pathways. Okay, it will activate all the catabolic pathways. Okay, catabolic pathways are the ones which will lead to breakdown and which will produce glucose. Okay, so those are known as your catabolic pathways. So in fasting or starvation, we definitely need energy or glucose, and this energy is usually derived from new glucose synthesis. That is what is gluconeogenesis. Whereas it is also taken from the glycogen, that is the storage form of glucose. Okay, so glycogenolysis or glycogen breakdown by both of these pathways which are activated by glucagon, it will increase the blood sugar levels during fasting or starvation state. So here the best answer would have been gluconeogenesis and glycogenolysis are the pathways with the help of which glucagon aims to produce glucose or increase the blood sugar levels. Okay, no issues with this, anybody? I hope this was pretty easy, right? Glycolysis, though we know glycolysis is a catabolic pathway. Please remember, glycolysis, though it is a catabolic pathway, it is not activated by glucagon. It is activated by insulin. ये भी हमने किया था, all the exceptions, right? So we know all the anabolic pathways are activated by insulin and all the catabolic pathways are activated by glucagon, except two, that is glycolysis and link reaction, which are activated by insulin. That was the basic funda, right? So glycolysis is not activated by glucagon. Glycogenesis is usually done, that is glycogen is produced or synthesized usually in fed state. जब glucose ज़्यादा होगा तो store होगा ना. So glycogenesis is usually done in fed state and not in fasting or starvation state. So definitely this answer is ruled out. And only gluconeogenesis, no. Glycogenolysis is the first one and then followed by gluconeogenesis. ठीक है? Moving further now. Next question, question number 130. A boy presented to the OPD with voracious appetite and overall swelling of different body parts. He is most likely to suffer from. So here, most of the people had a confusion. A child who is presenting with voracious appetite. So voracious appetite is usually a feature of marasmus. Okay, voracious appetite is a feature of marasmus, guys. Whereas overall swelling of different body parts is suggestive of edema. So there is a diffuse edema all over the body. Okay, na? So he is most likely to suffer from. So guys, please remember, if he is having edema, that means it is more likely due to protein malnutrition, right? It is mainly due to protein malnutrition. Important, right? And as we know, protein malnutrition or edema is likely a feature of kwashiorkor and not marasmus. So marasmus is definitely ruled out. Though appetite is voracious, but due to edema, we can rule out directly marasmus from this. Bulimia nervosa is a eating disorder commonly seen in adolescent females and not in children. First thing. Secondly, the patient would have a binge eating disorder. The patient will binge eat a lot of food in short duration of time and then will do purging. Okay, so that is definitely not a case. So either kwashiorkor or marasmic kwashiorkor was the confusion. So please remember, guys, if they would have given, like most of the faculties of pediatrics, they are of the same point of view that if they would have given that the edema is only located in like the central body parts or something like that, then the answer would have been marasmic kwashiorkor. But here, as they are saying, there is diffuse edema all over the body, though some cases of kwashiorkor can have voracious appetite, and therefore the most likely answer would be kwashiorkor in this condition. ठीक है? So marasmic kwashiorkor क्यों नहीं होगा? दोनों के features है, voracious appetite of marasmus and edema of kwashiorkor. But please remember, they have given that edema is diffusely spread all over the body, different body parts में. Therefore, the most likely answer to this question would be kwashiorkor. Please remember, most of the faculties are of this opinion. ठीक है ना? याद रखना, because few cases of kwashiorkor, though we know in kwashiorkor the child would be lethargic and the child would be inactive, okay, but in few cases of kwashiorkor the child can have voracious appetite as well. Okay, so this was the question. We have discussed everything about kwashiorkor. There is flack sign, there is flaky pain, dermatosis on the skin, the child is called as a fat sugar baby, all of this. And marasmus mein, and in kwashiorkor the child has moon-like feces, obesity is seen, and it is a protein malnutrition predominantly, whereas in marasmus there is a protein energy malnutrition, mainly calorie intake is less. Here the child will have prominent ribcage, monkey or old man like faces, all of that. Question number 131 now. Peripheral conversion of T4 to T3 is done by. As we know, guys, please remember the most abundant thyroid hormone which is produced is T4 or thyroxine. Yaad rakhna, the most abundant thyroid hormone which is produced is T4, but the most active thyroid hormone is T3. The most active thyroid hormone is T3. Okay, so it is tetraiodothyronine या फिर triiodothyronine. So tetraiodothyronine is also called as thyroxine, right? It is also known as thyroxine. So it is the most abundant form. So almost 98% of thyroid hormone which is produced is thyroxine, but the active form is T3. So we need to convert thyroxine or T4 to T3 peripherally when it needs to act, right? So when it is converted from T4 to T3, it is done by an enzyme which is known as option A, deiodinase. Most likely people are telling there was deiodinase 1, 2 and 3 in the option. I'm not sure about that. Please remember. So more likely you need to mark it as deiodinase 1 then. Okay? So deiodinase is the enzyme which will convert thyroxine or T4 to T3 peripherally. Okay? Yaad rakhna. And the drug, there was also a question on the drug. The drug which usually blocks this peripheral conversion of thyroid hormone is nothing but propylthiouracil or PTU. Yes, propranolol also blocks the peripheral conversion of thyroid hormones. Okay? Yaad rakhna. Please remember this. No issues with this, anybody? Thyroid peroxidase, guys, is the rate limiting enzyme of not peripheral conversion. Rather, it is the rate limiting enzyme of thyroid hormone synthesis. So thyroid hormone बनने की अगर rate limiting enzyme पूछते वो, then definitely it would have been thyroid peroxidase, right? And thyroid peroxidase, as we know, usually there are antibodies formed against this enzyme, usually in cases of lymphocytic Hashimoto's thyroiditis. Moving further now, question number 132. Which of the following is true in regards to Michaelis-Menten constant? So Michaelis-Menten constant, we know, we have discussed this in biochemistry, even in pharmacology. This Michaelis-Menten constant is written as Km. Okay, so Michaelis-Menten constant is written as Km. And मैंने जब तुम्हें enzyme inhibitions बताया था, I told you like competitive, non-competitive, or uncompetitive enzyme inhibitions. In both the subjects, we have discussed this. I have given you a table. So over there, I told you that Km and Vmax are to be looked for. Okay, Vmax is easy, that is maximum velocity of the reaction, but Km is equivalent to the substrate concentration. That means Km, or the Michaelis-Menten constant, is directly proportional to the substrate concentration. It is directly proportional to the substrate concentration. याद रखना. So substrate की अगर level बढ़ाओगे, so that is what will increase the Km. ठीक है? So for example, if I talk about the 3 types of enzyme inhibition, as we know, first one was competitive, second one was non-competitive, and third one was uncompetitive enzyme inhibition. So those factors I told you, first is Km and second is Vmax. In competitive and enzyme inhibition, what happens usually? There is a substrate and there is the there is the inhibitor. Okay, so the substrate and inhibitor usually has the same binding site on the enzyme. Okay, so there is the same binding site on the enzyme for the substrate as well as the inhibitor. So therefore they need to compete with each other, and jiska concentration zyada hoga, whichever will have a higher concentration will win the competition, right? So here definitely, if we need to keep the velocity of the reaction same, we need to increase the substrate concentration, because if we increase the substrate concentration, then and then only the maximum velocity will remain same, or the reaction will occur. Okay, अगर substrate concentration कम हो जाता है और inhibitor का concentration बढ़ जाता है, then definitely the Vmax will go down or the reaction will be inhibited, right? That is important. In non-competitive, definitely, as we know, there is one site for the substrate, whereas the another site is for the inhibitor. So they have different sites. So definitely, whatever you do, how much concentration you increase of the substrate, definitely the inhibitor is going to bind to the enzyme, and definitely it will inhibit the enzyme. ठीक है ना? So at any case, definitely the Vmax will go down. In any case, the Vmax is going to decrease because the inhibitor has a different site to bind. It does not need to compete with the substrate now. So here, whatever we do with the substrate, definitely the Vmax is going to go down. So better keep the substrate concentration same. Whereas in uncompetitive inhibition, definitely both of them go down. Okay, no issues with this. So I hope this was easier for all of you. It was not enzyme concentration, it was the substrate concentration. Okay? Most of the people are saying there was also first order kinetics and zero order kinetics mentioned in this question. Please let me know if it was, so I can answer it accordingly in the comment box. Okay, please remember this. Moving further, guys, now question number 133. Which among the following is specially found in gram-positive organisms? So now these were the options that people recalled actually, but I feel so there is some, like, we need some of the correction in this, because please remember, guys, capsule is found in gram-positive as well as gram-negative organisms. So definitely this is not a special feature of gram-positive organisms. Okay? So ruled out. Flagella, flagellated organisms can be gram-positive or gram-negative. So this is also not a differentiating feature. We are left with two options, that is lipopolysaccharide and peptidoglycan. Please remember, guys, lipopolysaccharide is absent in gram-positive organisms. Lipopolysaccharide is absent in gram-positive organisms. Rather, they are asking specially found in gram-positive organisms. So lipopolysaccharide is rather absent in gram-positive organisms. It is not present in gram-positive. It is present in gram-negative organisms. ठीक है ना? So अगर exception पूछा था, then the question would have been, which among the following is not found in gram-positive organisms? Then your answer would have been lipopolysaccharide, if these were the options. Okay? Because peptidoglycan, as we know, peptidoglycan, only the layers will differ. Okay? So in usually gram-positive organisms, it would be like 100 layer thick, but in gram-negative, it would be 1 to 2 layer thick. Okay? So that is the difference. The number of layers will vary in cases of gram-positive or gram-negative of the peptidoglycan layer. The number will vary only, but peptidoglycan layer is also present in gram-positive as well as gram-negative organisms. Though the number of layers vary, that is also present. So agar ye options say, then the question would have been, which among the following is not found in gram-positive organisms? Or agar specially found hota, so please remember here, if you need to choose anything, then peptidoglycan would have been the answer. या फिर please remember, please give me a proper recall कि lipopolysaccharide था या teichoic acid था, because teichoic acid is definitely a special feature which is found in gram-positive organisms. Okay, teichoic acid is not found in gram-negative. It is only a special feature of gram-positive organisms. So अगर teichoic acid था, then that would have been your answer. अगर यही चार options थे, if you need to choose best, then definitely go for peptidoglycan, because there are 100 layers of peptidoglycan in positive and 1 to 2 layers in negative. Okay, so that can be a differentiating feature. But lipopolysaccharides are rather absent in gram-positive. Okay, so either the question was framed differently or the options are different. Question number 134 now. A patient presents with abdominal pain and diarrhea. Which among the following is the best investigation? Okay, so this was the question. I don't think so there would have been any issue with this. So a patient presents with abdominal pain and diarrhea, which among the following is best investigation? So abdominal pain and diarrhea usually due to fecal-oral route of contamination. Okay, along with fever, some people are saying definitely fever was also mentioned for few days. 1 or 2 days ka fever bhi mentioned tha. So definitely the diagnosis over here becomes enteric fever, and enteric fever is nothing but typhoid, right? So they have a question on enteric fever or typhoid, please remember. And as we know, for typhoid, we have discussed about all the investigations. In the first week, definitely, the mnemonic is BASU, right? The mnemonic is BASU. In the first week, we do a blood culture. In second week, we do a agglutination test. And this agglutination test is called as the Vidal test. Third week, we do the stool culture. Third week, we do the stool culture. And fourth week, we do the urine culture. If you need to choose the best out of all of them, as we have discussed already, the best out of all of them is definitely the blood culture. Overall best is definitely the blood culture. So if you need to choose one, definitely go for blood culture. We send blood culture of the patient and we can isolate the organism on that. On the blood culture, we can see the growth of the organism and definitely we can treat the patient accordingly. Okay, no issues with this anybody. So it is more likely a case of typhoid or enteric fever they wanted to ask you. Moving further, guys, now in typhoid, as we have discussed already, the treatment of choice is usually drugs like Cefixime. Okay, antibiotics de jayegi, Cefixime. Third or fourth generation cephalosporins are usually used nowadays. Next question was question number 135. Which organism does not have a cystic stage? Definitely, Dr. Vikas sir would have covered in his sessions as well. Which organism does not have a cystic stage? So please remember, guys, usually here, Trichomonas vaginalis usually. Trichomonas vaginalis does not contain a cystic stage. ठीक है, उसमें कोई cystic stage नहीं होता है. In Trichomonas vaginalis, please remember, it does not have a cystic stage. It will only have a trophozoite stage. ठीक है, it will only have a trophozoite stage. No issues with this anybody. So as we know, Giardia lamblia usually has the trophozoite, which is monkey face shaped or teardrop shaped or tennis racket shaped, whereas the cyst is known as a quadrinucleate cyst in cases of Giardia lamblia. ठीक है. Whereas Ankylosing duodenal and Entamoeba histolytica also have cystic stages. Okay, so only organism out of all of them which do not have a cystic stage is Trichomonas vaginalis. Moving to question number 136. Which among the following is used for disinfection of blood spillage? A sarkari question again. I have told you in my like Vikas sir would have discussed this in micro. I have told you multiple times in PSM as well. Repeated multiple times. Which among the following is used for disinfection of blood spillage? Pehle question thoda clinical aaya tha, like a nurse usually spills the blood while collecting samples, and now what should be used for disinfection? So the disinfecting agent for blood spills or blood stains usually on floor, it is nothing but option D, 1% sodium hypochlorite. Okay, what is the disinfecting agent used for blood spillage? 1% sodium hypochlorite should be used. Okay, all of the others I also have discussed. As we know, isopropyl alcohol. Isopropyl alcohol, I told you, it is used for disinfection of the stethoscope or thermometer. Isopropyl alcohol is used for disinfection of steth or thermometer. Right, important. Whereas hydrogen peroxide, it is used for disinfection of the wound. Okay, hydrogen peroxide is used for washing or disinfection of the wound properly. Okay, so that is important. We have also discussed about 2% glutaraldehyde, also known as Sidex. Okay, it is used for disinfection of endoscopes. I hope there was also a question on Petri dish. Some people are saying there was only Petri dish. Some people are saying there was plastic Petri dish. Okay, so please let me know what it is. Actually, for Petri dish, the disinfecting agent that we use is ethylene oxide. For Petri dish, we use ethylene oxide. ठीक है ना? So no issues with this. Microbiological waste usually goes for autoclaving, guys. Disinfecting agent that we can use is ethylene oxide. ठीक है? Otherwise, it will go for autoclaving. Moving further now, question number 137. A child was infected with negative sense RNA virus with neuraminidase and hemagglutinin present on the surface. Which among the following virus is the cause? So I don't think so there would have been any question. Most of the people are saying RSV, RSV, RSV. I'm not sure why people are marking it as RSV, guys. This is a classical funda. Yehi image aayi thi pehle. Now they have given a straightforward question. So please remember here, if it is containing neuraminidase and hemagglutinin on the surface of the virus, definitely it is likely to be option A, influenza virus. Okay? It is likely to be option A, influenza virus, and the child might be suffering from flu. Okay? So koi bhi flu ho sakta hai depending on the type of influenza which it is affected. So RSV may usually, please remember, RSV will not have hemagglutinin or neuraminidase on the surfaces usually. It is a characteristic feature of influenza. Okay, negative sense RNA virus. Moving further, question number 138. Which among the following is the drug used for treatment of Legionnaires disease? So Legionnaires disease, we know it is caused by organism known as Legionella pneumophila. It is caused by organism known as Legionella pneumophila, and as we know, Legionella pneumophila is a common cause of walking pneumonia, also known as atypical pneumonia. It is a common cause of walking pneumonia or atypical pneumonia, right? And then this atypical pneumonia, along with the pneumonia features, the patient will also develop diarrhea. And as we know, Legionella infection or Legionnaires disease is usually due to exposure to AC or humidified air. It is usually due to exposure to AC or humidified air. In that environment, usually the Legionella pneumophila organism sustains. Okay? So it is a common cause of atypical pneumonia along with diarrhea. Along with that, it also leads to a severe condition known as Legionnaires disease. Okay? No issues with this, anybody? So here the drug of choice is definitely option C, azithromycin. Okay, the best drug to be given in Legionnaires disease is definitely azithromycin. Okay, now, as we know. No issues with this, anybody? I hope so. This was a straightforward question. Nothing to be discussed as such. Question number 139 now. A middle-aged patient on workup revealed to have suffer from one rare form of pyruvate dehydrogenase deficiency, for which he has developed high anion gap metabolic acidosis. What is the best dietary advice that should be prescribed from the following for this patient? So you need to understand this question at first. Middle-aged patient tha, now he's suffering from a rare form of enzyme deficiency, and this enzyme is pyruvate dehydrogenase. As we know, pyruvate dehydrogenase is the rate-limiting enzyme for which reaction? It is the rate-limiting enzyme for link reaction. This link reaction will connect glycolysis to TCA cycle or Krebs cycle. Okay? So this is the linking reaction between the glycolysis and TCA cycle. Okay? And the rate limiting enzyme is pyruvate dehydrogenase. So this patient is having deficiency of pyruvate dehydrogenase. So pyruvate dehydrogenase ka kaam kya hota hai in link reaction? It will convert a 3-carbon compound, that is pyruvate, to acetyl coenzyme A. And this acetyl coenzyme A, which is a 2-carbon compound, it will then further go into the TCA cycle or the Krebs cycle. Okay? So this is the function of pyruvate dehydrogenase. But in case this pyruvate dehydrogenase enzyme is deficient in the patient, this link reaction would be inhibited. Link reaction agar nahi hogi, there would be excess accumulation of pyruvate inside the body. And as we know, if pyruvate is accumulated, definitely, if link reaction is not working, there would be anaerobic glycolysis. And anaerobic glycolysis ki wajah se, the pyruvate would be converted to a dead end product, that is lactate or lactic acid, and therefore the patient is suffering from high anion gap metabolic acidosis. Lactic acidosis ho gaya patient mein, right? So which among the following is the best dietary advice that should be prescribed for this patient? So definitely, if we give carbohydrates to the patient, the carbohydrates will undergo breakdown. It will lead to glucose, and this glucose will undergo breakdown by glycolysis. Jab glycolysis hoga, there would be excess of pyruvate which is produced. So definitely we don't need to give high amounts of carbohydrate to the patient. Rather, we need to decrease the amount of carbohydrate in his diet. So only carbohydrate is definitely ruled out. Rather, we need to decrease the carbohydrate intake in this patient. High carbohydrate is ruled out again. So we have two options, either high fat, low carb diet or a high protein, low carb diet. Now, important thing is how to choose. See, please remember, like low carb diet to deni hi hai. Okay. Important thing is to differentiate between high fat or high protein. If we give high protein to the patient, guys, please remember some of the proteins as we know. Okay, some of the amino acids as we know, like alanine or some other glucogenic amino acids, jinka naam suna hoga tumne, right? Some of the amino acids we discussed, some of the amino acids are glucogenic, some of them are ketogenic, and some of them are both, right? So most of the amino acids are glucogenic, and the most glucogenic amino acid, ye maine one-liner bataya tha, that is alanine, right? So alanine can be converted to pyruvate again, theek hai na? So alanine can be converted to pyruvate, and that can lead to further deterioration of his symptoms. Okay? So important thing is you cannot give high protein diet also to this patient, because if you give high protein diet, excess of amino acids by the transamination reaction would be converted to pyruvate again. But as we know, एक मैंने statement दी थी, therefore option D is ruled out. एक मैंने statement दी थी that fats cannot be converted to carbohydrate, right? This was the statement. Fats cannot be converted to carbohydrate except two, as I told you already, glycerol and propionic acid. These were the two exceptions, but usually most of the fats are not converted to carbohydrates, and therefore definitely a high fat and low carb diet would be the best recommendation for his dietary intake in this patient. Okay? No issues with this. So fats are never converted to carbohydrates, so they would not be converted to pyruvate. Rather, fats, when they undergo beta oxidation of fatty acid, that is fatty acid breakdown, then they would be converted to acetyl coenzyme A, and this acetyl coenzyme A will go into the TCA cycle or the Krebs cycle, because as we know, TCA or Krebs cycle is a vital cycle of the cell. It needs to occur at any point. Okay, whether the patient is fasting, fed, starvation, diabetes, kuch bhi ho, TCA to hona hi hai. So TCA अगर होना है तो उसका substrate भी होना चाहिए, इसका precursor भी होना चाहिए, that is acetyl coenzyme. ठीक है? So if you're decreasing carbohydrate intake, you need to increase you need to increase fat intake in the patient. Moving further now, question number 140. A patient sustained a road traffic accident, now presented with pain and swelling in the forearm. X-ray has been given below. What is the treatment in this condition? Now, some people are saying that both the forearm bones were fractured in this X-ray. Some people are saying only the radius was fractured distally and there was dislocation of the radioulnar joint, the inferior or the distal radioulnar joint. So if it was only radius fracture distally, along with dislocation of the distal radioulnar joint, then that is a classical case of Galeazzi fracture. ठीक है, अगर एक ही bone fractured था. But people are saying that both the forearm bones were fractured, then definitely it is not a Galeazzi or a Monteggia, rather it is a forearm bone fracture, you can just say, okay, fracture of the forearm, okay. So both the bones of the forearm, that is radius and ulna, are fractured over here. When the patient has sustained a road traffic accident, there is pain and swelling due to the fracture. Now, what is the treatment option in this patient? So please remember, I have given you that I had given that there are 3 fractures of necessity. Okay, there are 3 fractures of necessity. Dr. Mukul sir would also have discussed in his sessions. I have also told you, reiterated multiple times, that there are 3 fractures of necessity. When what are fractures of necessity? The fractures which will always and always require open reduction and internal fixation. They cannot be managed by closed reduction. So such factors which are managed by open reduction and internal fixation are called as fractures of necessity. Okay, and these are usually the intra-articular fractures, the fractures which are usually present at the level of joint. So first are intra-articular fractures. Second, as we discussed, is the lateral condylar fracture of humerus. It is the lateral condylar fracture of humerus, whereas the third one was the Galeazzi or the Monteggia fractures of the forearm. That means the forearm bones, if they are fractured, definitely they will need open reduction and internal fixation, no closed reduction. So apply POP cast and conservative management? No, it is never done. Closed reduction and POP cast? No, closed reduction will not help the bones to fuse properly. Okay, so closed reduction with nail insertion? No, it is also not done if both the bones are fractured, or even if there is a dislocation, that is Galeazzi or Monteggia fracture. It will always need option A, open reduction and internal fixation. No issues with this, anybody? Moving further now, question number 141. Again, ECG again. There were 2 ECG questions, I feel. One I discussed yesterday, that was atrial fibrillation. The second was a patient presented with palpitations and syncopal attacks. The ECG is given below. What is the likely diagnosis? So if the patient is having palpitations or syncopal attacks, more likely the cases the patient might be having arrhythmia, due to which the cardiac output is compromised, and that is the reason the patient is having recurrent syncopal attacks usually. Okay? So over here also you can see there is an arrhythmia in this patient. What is seen over here? Definitely you can see, first thing that we check for is definitely the rhythm. Okay, whether it is a sinus rhythm or a whether it is a normal rhythm or an abnormal rhythm. So here you can see that the distance between each RR interval, is almost equal. Okay, there is almost one big box between each RR wave. Okay, so more likely the rhythm is sinus or normal. But problem is what? That the heart rate, if you calculate, as I have already told you, heart rate कैसे calculate करना है? 300 divided by the number of large boxes. 300 divided by the number of large boxes. And here you can see the number of large boxes is only 1. If we need a normal heart rate, usually the number of large boxes between 2 RR waves should be 3 to 5. अगर 5 से ज़्यादा है, then the patient is having bradycardia. But अगर 3 से कम one large box है, then the patient is having tachycardia. Here, the patient is only having almost 1 large box. So 300 divided by 1, the heart rate of this patient is almost 300 beats per minute. That means definitely the patient is having tachycardia. Okay, but which type of tachycardia is seen? Let's see. Okay, it cannot be a sinus tachycardia, because in sinus tachycardia, all the waves should be seen. That is, a P wave should be seen, a normal narrow QRS complex should be seen, and a T wave is also seen usually. Okay, but here you can see the patient is not having any P wave. Okay, P wave दिख नहीं रही है. You can rather see the P wave is actually overridden by the T wave. ये जो दिख रही है ना, that is usually the T wave. It is not the P wave. Okay, so it is the T wave which is seen. QRS complex is not narrow, definitely. If the QRS complex is narrow, as we know, it is not a ventricular pathology. It is not a ventricular arrhythmia. ठीक है, तो ventricular ruled out है. So it is a supraventricular or a atrial arrhythmia. ठीक है, here P wave is also absent, so definitely it is a atrial arrhythmia or atrial tachycardia, which is also called as supraventricular tachycardia. And as it starts all of a sudden, therefore it is called as paroxysmal supraventricular tachycardia. Same ECG I have discussed with all of you. I don't think so there would have been any difficulty you answering this. So it was a straightforward question. So here the answer would have been option A, PSVT, paroxysmal supraventricular tachycardia. If that was not an option, then SVT, supraventricular tachycardia. Okay, whatever it was, that would have been the best answer. We have discussed about the management also. The first line management in PSVT is definitely a carotid sinus massage. First line they have asked you previously, it was a carotid sinus massage. And the drug of choice, if they ask you, definitely it is IV adenosine. Okay, that is the shortest acting antiarrhythmic drug. Okay, half-life of 10 seconds almost, right? That we have discussed. Atrial fibrillation, atrial flutter. Flutter may usually we know there are normal QRS complexes, there is normal RR interval, but the problem is there would be sawtooth waves. Okay, here no sawtooth waves are usually seen. Next, question number 142, if I talk about, here a child took some medicine and has a rash on his body as shown. Which among the following is the cause? So please remember, guys, most of the people are saying that the child took some medicine. There was some history of some medicine intake and such kind of a rash was given on the hand or on his body. Okay? So if a specific rash is given, not all the bodies involved, then it is more likely to be a fixed drug eruption. Okay, here it is to be a FDE, fixed drug eruption. And whenever the patient will stop taking the drug, the rash will disappear. And whenever the patient will again start taking the drug, the rash will again reappear. Okay? So that is what is called as a fixed drug eruption. The rash will again reappear at the same site when the patient restarts the drug. Okay? So that is what is a fixed drug eruption. But most of the people were saying that it is Stevens-Johnson syndrome. So please clarify me. If it was Stevens-Johnson syndrome can also occur due to drug intake. And as we know, which anti-epileptic drug, as I've always discussed with you, lamotrigine intake is definitely associated with Stevens-Johnson syndrome, where there is peeling of skin. So agar peeling of skin or diffusely the rash was present all over the body, then definitely it is more likely to be a Stevens-Johnson, because in fixed drug eruption, only a specific part of the body is involved, because people told me it was only the hand that was involved. So please correct me for this question, because I'm having a doubt what it was actually. Okay? Moving further, question number 143. I discussed this question already while I was discussing the previous question of myasthenia gravis. So myasthenia gravis is which type of hypersensitivity? As we know, as I discussed, myasthenia gravis is an autoimmune condition, right? So autoimmune means what? It is usually due to the presence of preformed antibodies in the body. Okay? So preformed antibodies hoti hai, which will target the neuromuscular junction. Okay? So the channels at the neuromuscular junction are targeted by these preformed antibodies, and that is what leads to the muscle weakness in the patient. And this muscle weakness or ptosis will show diurnal variation, worsening in the evening of the symptoms is seen. So definitely, if it is due to preformed antibodies in the patient, it is a cytotoxic hypersensitivity or a antibody-mediated hypersensitivity. And we have the mnemonic that is acid for hypersensitivity. Type 1, that was also a question, it is anaphylaxis. Type 2, it is cytotoxic or antibody mediated. Type 3 is immune complex mediated, that is antigen antibody complex mediated. Okay, and type 4 is usually delayed hypersensitivity or cell mediated hypersensitivity. Almost everything as I have discussed with all of you. So here it is type 2 hypersensitivity, guys, if you do not have type 5 in the option. As I've always told you, Goodpasture syndrome, myasthenia gravis, the more likely answer would have been type 5 hypersensitivity. But agar wo option mein nahi tha, then you can mark type 2, because type 5 is nothing but a subtype of type 2 itself. Okay? Moving further now, question number 144. The cells which are responsible for graft rejection are. So I hope this was a pretty straightforward one. The cells which are responsible for graft rejection. It is option B, T cells. ठीक है ना? It is option B, T cells usually. ठीक है? That is, we have two types of T cells or T lymphocytes. These are usually CD4 T cells, which are also known as T helper cells, and we have CD8 T cells, which are also known as cytotoxic T cells. ठीक है? So T helper cells or CD4 cells, इनका काम क्या होता है? They are having the function of suppression. They are having the suppression of. They are having the function of memory. They are having the function of activation of the B cells. So naive B cells are activated and they will differentiate into plasma cells and finally produce antibodies. Okay? So all these functions are done by the helper T cells or the CD4 T cells. Whereas CD8 T cells are cytotoxic. By the name itself, you can know they will kill the cells. Okay? So जो graft होता है, that is usually killed by the CD8 T cells. Okay? So usually graft rejection, the cells which are responsible are the T cells. We have discussed all of this. I don't think so there would have been any issue. There were previous questions on MHC also. I told you MHC is also one of the important topics. CD4 has MHC2 and CD8 has MHC1 to bind with it. Okay, na? And we discussed about graft rejection also. If there is a hyperacute graft rejection, it is type 2 hypersensitivity, whereas acute and chronic graft rejections are type 4 hypersensitivity. Okay? Moving further now. Question number 145. A patient was suffering from iron deficiency anemia, which is the stain used to confirm the depletion of iron stores. As we know, the most common type of anemia or nutritional anemia is iron deficiency anemia. And usually in iron deficiency anemia, there is decreased stores usually. The iron stores, that is definitely, iron stores are nothing but ferritin, right? So iron stores of ferritin, and it is the investigation of choice for diagnosis of iron deficiency anemia. So definitely serum ferritin level goes down in cases of iron deficiency anemia. To confirm the diagnosis of iron deficiency anemia, we need to check for the iron stores or the serum ferritin. So which among the following is the stain used? So as we know, the stain used for iron, we have discussed it multiple times. The stain used for iron is nothing but option B, Prussian blue stain. Okay, the stain used for iron is Prussian blue stain, and the reaction which it shows is known as the Pearl's reaction. I've discussed it in pathology. I discussed it in integrated sessions of hematology. बहुत बार डिस्कस कर लिया था. I also discussed you about the Azarin red stain and the von Cosa stain. So Azarin red and von Cosa stain are the calcium stains which are used. Azarin red stain will stain the calcium red, whereas von Cosa will stain the calcium black. Okay, please remember this. No issues with this. Moving further, question number 146. A middle-aged man presented with hypercalcemia. That means increased serum calcium levels are there. Normal serum calcium is 9 to 11 milligram percent. So here it would be more than 11 milligram percent usually. With feature usually more than 13 ho sakta hai. Is case man coming to it. With features consistent of renal insufficiency. That means there is renal damage. Okay, there is also renal damage in the patient. On CBC, complete blood count, the RBC count was severely decreased. That means the patient was having anemia as well. And the X-ray shows multiple lytic lesions. So multiple punched out lytic lesions, yeah, multiple osteolytic lesions, agar wo bolte hai, definitely, that is more likely to be a case of multiple myeloma. So either it is a middle-aged man or an elderly patient presenting to you with low backache. I told you the first differential diagnosis should be multiple myeloma. There are CRAF features in this patient. What do we mean by CRAF? We have discussed. There are 3 diagnostic features of multiple myeloma. First, on bone marrow biopsy, okay, on bone marrow biopsy, there should be more than 10% of plasma cytosis. There should be more than 10% of plasma cytosis. Second, usually on serum or urine electrophoresis, there should be a M peak which is seen, or a church spire appearance on electrophoresis due to increase in the level of light chain of antibodies, due to increase in the level of light chain of antibodies or gamma globulins. Okay? Whereas the third diagnostic feature is any one of the CRAF feature or any one of the myeloma defining events. So C goes for hypercalcemia, R goes for renal failure, renal damage, A goes for anemia, and B goes for bony lytic lesion. So there are 3 features, almost all of them. There is hypercalcemia, there is renal failure, there is anemia, there is bony lytic lesions. So definitely the diagnosis over here is option B, multiple myeloma. Okay? No other condition. I hope this was easy. Hyperthyroidism is definitely not a cause. Hyperparathyroidism bhi agar hota, please remember, hyperparathyroidism bhi agar hota, definitely the patient could have hypercalcemia. On long term, there can be renal insufficiency. There can be multiple lytic lesions as well. And on skull, definitely in multiple myeloma, we get a raindrop skull. But in hyperparathyroidism, we get a pepper pot skull or a salt and pepper skull. Okay? But please remember, RBC count would not have decreased in cases of hyperparathyroidism. Anemia is not a feature of hyperparathyroidism. Okay? No issues with this, anybody? Moving further, question number 147. A 2-year-old baby is presented to the OPD with the following complaint. What is this complaint? People were saying it is inverted foot. Okay, so inverted foot to nahi hai. This is actually CTEV, the deformity that we have discussed in orthopedics. Okay, Mukul sir would have also discussed this definitely. It is CTEV, that is congenital talipes equinus varus. Kya hai wo? Congenital talipes equinus varus. This is the deformity seen usually at birth in a child. And how would you manage this patient? So we have discussed in my orthopedics discussion sessions, I have discussed about the management of CTEV. If the child presents to you in infancy, that means within 1 year of age, if the child presents to you with congenital talipes equinus varus, definitely the treatment of choice would have been serial manipulation and casting. Okay, and this casting is actually called as Ponseti casting. This is known as the Ponseti casting. So here you manipulate each time and then you apply a cast in particular position. Okay, particular position. That is what is called as serial manipulation and casting. That is usually done in infancy or till 1 year of age for CTEV. Okay, that is what is Ponseti casting. And please remember here the order to be followed is cave, as we have discussed. Okay, the order of collection to be followed for Ponseti casting is cave. That means you first need to treat the cavus, then you need to treat the adduction and varus deformity, and then finally you need to correct the equinus deformity. But here the child is more than 1 year of age, and as we have discussed, usually between like 1 to 5 years of age, if the child presents to you sorry, if the child presents to you between 1 to 3 or 1 to 5 years of age, the best choice would have been option B, posteromedial soft tissue release. Okay, the best choice would have been posteromedial soft tissue release. If the child is between 3 to 10 years of age, definitely you can go for the Dillwyn-Evans procedure or Dillwyn-Evans osteotomy. And if the child is more than 10 years of age, then definitely you need to go for triple arthrodesis, where we will fuse 3 joints. ठीक है ना? Calcaneonavicular joint, calcaneocuboid joint, and subtalar joint. These 3 joints are fused together. That is what is triple arthrodesis procedure, which is done for CTEV correction after 10 years of age. But here the child was between 1 to 3 years of age, so you can go for posteromedial soft tissue release. No issues with this. We have also discussed about the splint of CTEV, that is your Dennis Brown splint. Okay? Moving further, question number 148. A classical question, Sarkari again. A patient comes to the OPD with pain and swelling at the knee joint. Okay? So at the knee joint, the patient is having pain and swelling. The X-ray knee has been given below. What is the appropriate diagnosis? So the X-ray knee, usually it shows that at the upper end of tibia, starting from the metaphysis till the joint almost, or till the epiphysis, starting from the metaphysis till the joint, or till the epiphysis, we can see a lytic region, or it is actually known as the soap bubble appearance. Kaisa appearance dikh raha hai? This is what is known as the soap bubble appearance. So soap bubble appearance at metaphysis is definitely a case of giant cell tumor or osteoclastoma. Okay, definitely it is a classical funda, and the most common site for giant cell tumor, they have given the most common site, that is upper end of tibia. Second most common is the lower end of femur, and the third most common is the distal end of radius. Okay, so people are saying distal end of radius, but most of the people have given me a recall that it was usually the knee joint, and the upper end of tibia was having the soap bubble appearance. Okay, and usually the soap bubble appearance will extend from the metaphysis till the joint. This is the classical case of definitely option B, giant cell tumor. And if they would have mentioned the age, that would have been pretty easier. It is around the 3rd decade of life, giant cell tumor or osteoclastoma. The other name is osteoclastoma, which is pretty much common. Okay, ठीक है, याद रखना. Usually, as I told you, for diagnosing bone tumors, you definitely need to look for the age of the patient. Second, you need to look for the site of the bone which is affected. And third, you need to look for the bone which is affected. Okay? So these are the 3 important things. So definitely osteosarcoma is not a case, because osteosarcoma is more predominant in the 2nd decade of life. And over there on the X-ray, it is not the epiphysis which is also affected. It is only the metaphysis which is affected. And due to the periosteal reaction, you can see the sun ray or sunburst appearance along with Codman's triangle. Please remember this. Okay. Whereas aneurysmal bone cyst also we have discussed. Aneurysmal bone cyst also can give us a soap bubble appearance. It can also give us the soap bubble appearance. Please remember this. Okay. Whereas the site for aneurysmal bone cyst is definitely the upper end of humerus. It is definitely the upper end of humerus, as I told you. As I discussed this, soap bubble appearance. Okay. Soap bubble appearance, usually it is the upper end of the humerus. No issues with that, anybody? And other soap bubble appearance occurs in the diaphysis, then it is a tumor known as adamantinoma, which is a rare tumor. Okay. Moving further, question number 149. Which among the following is the most common site for genital TB? So I hope so. This was an easy question. This was a straightforward one. So as I've discussed about tubercular pelvic inflammatory disease or tubercular PID, I discussed about tubo-ovarian abscess, I discussed about hydrosalpinx, and as I discussed about PID, I told you the most common site affected in genital TB or any pelvic inflammatory disease is definitely option B, fallopian tube. Okay, and it will lead to salpingitis in the patient. Inflammation of the fallopian tube is known as salpingitis, and that can cause adhesions after the infection, and that would lead to infertility in the patient. Okay, so that we have already discussed about this. I don't think so there would have been any issue answering this. Most of the people are saying there was also one question on port spine. Port spine is nothing but tuberculosis of spine, and port spine usually would have been the diagnosis if they have given an MRI. People are saying they have given an MRI, and on MRI usually there was destruction in and around the vertebra. That means this is the vertebral body. So around the vertebra, like lower part of the upper vertebra and upper part of the lower vertebra were damaged. That means this is what is the most common site of port spine. That is what is known as paradiscal. This also we have discussed. Paradiscal is the most common site of port spine or TB spine. So if the lower part of upper vertebra or upper part of lower vertebra, if both of them are damaged, that means surrounding the disc, if there is a damage which is seen, that is likely to be a case of port spine usually in the patient. Okay? Moving further, question number 150. A child was brought to ophthalmology OPD with white abnormal pupillary reflex in his left eye. So as I've always told you, white abnormal pupillary reflex. मैंने क्या बोला था? They will not directly give you the condition, they will not directly mention leukocoria. Rather, they will mention a white abnormal pupillary reflex. This is what is known as the leukocoria, right? And as we have discussed already, leukocoria, last time also there was a question. They have just given an image. This time they described it, white abnormal pupillary reflex or leukocoria. The most common cause, I told you, it is retinoblastoma followed by congenital cataract. So let's see over here. There is leukocoria in the child. Along with that, on investigation, there is a cauliflower-like growth seen arising from the retina. So if you perform an MRI also, a pathognomic radiological feature of retinoblastoma is a cauliflower-like growth along with, or a mass along with calcification. That is the characteristic feature of the pathognomic feature on MRI. Whereas on histopathology, the most characteristic feature, the pathognomic feature on histopath is definitely flexner intestinal rosettes. Okay? So definitely if there is a cauliflower-like growth, definitely it is to be a tumor, not a cataract or not a glaucoma. So it is definitely option A, retinoblastoma. Straightforward question, pretty straightforward. And the treatment of choice we discussed, it is enucleation in this case. Congenital cataract, please remember, congenital cataract, though it shows leukocoria, but here there would not be any cauliflower-like growth arising from the retina. Okay? That is straight away ruled out. Congenital glaucoma, we discussed, there would be bullseye or ophthalmos in the child. There would be large eye, large cornea, large lens. Okay? That is the characteristic feature. Moving further, question number 151. A young adult male presents with low backache and he gives history of ulcerative colitis or inflammatory bowel disease. Okay? This was a pretty straightforward one. I hope so. Young adult male, I told you, if the patient, young adult male, presents with low backache, differential diagnosis is ankylosing spondylitis. First differential. If the patient is a elderly male presenting with low backache, the first differential is multiple myeloma. So here it is a young adult male presenting with low backache and gives the history of ulcerative colitis or inflammatory bowel disease. As we know, both of these conditions are HLA related and both of these are HLA-B27 related, right? Both of these are spondyloarthropathies and both of them are HLA-B27 related. Rather, I gave you the mnemonic for HLA-B27 related arthropathies. That was giraffe. J for juvenile rheumatoid arthritis, I for inflammatory bowel disease, that is Crohn's or ulcerative colitis, R for reactive arthritis, also known as Ritter syndrome, A for ankylosing spondylitis, and P for psoriatic arthritis. Along with that, also I told you that one more eye manifestation which is actually B27 related, it is anterior uveitis. So ankylosing spondylitis patient, they can give you along with inflammatory bowel disease or anterior uveitis like features that we have discussed. Similar question we discussed. And the X-ray lumbosacral spine has been given. What is the diagnosis in this condition? So here if I zoom in the X-ray of the lumbosacral spine, you can clearly see over here the most characteristic or the most pathognomic feature. Sabne bamboo spine dekh liya, but few of them definitely told me what actually I wanted. That was this picture, and this is the most characteristic picture of ankylosing spondylitis or the most pathognomic feature of ankylosing spondylitis, jiski wajah se low backache hota hai. It is not the bamboo spine or the dagger spine which is the most pathognomic. It is a late feature usually. The most pathognomic or the earliest feature is definitely bilateral sacroiliitis. Okay? So those who were my students, definitely they went on to look for, first of all, for the bilateral sacroiliitis. Definitely in the X-ray there was also fusion of the two vertebral bodies, that was known as the bamboo spine. That is a characteristic feature, but the most pathognomic or characteristic is definitely bilateral sacroiliitis. Some people were also saying there was calcification of the interspinous ligament. That is what is known as the that is what is known as the dagger sign. And if there is calcification of all the ligaments, then that is what is known as the trolley track sign or the tram track sign. Okay? So here the diagnosis was straightforward. It is ankylosing spondylitis. Please remember this. Okay? Spondylolisthesis is a subluxation of one vertebra over the other. Pot spine, as I told you, it is TV spine. And here the bamboo spine वगैरह नहीं दिखता. Here there is destruction or damage of both the vertebrae surrounding the disc. Okay? Upper as well as lower vertebra. Pyogenic spondylitis होता. So pyogenic spondylitis में again bamboo spine वगैरह नहीं दिखते. Here the patient would have presented to you with fever, with features of fever, high grade fever along with chills and rigors, all of that. No issues with this, anybody? I hope this was pretty easy. Question number 152. A patient presents with history of intermittent claudication. As I told you, we discussed in vascular surgery, intermittent claudication, that means pain on walking, okay, or pain on writing. That is what is known as intermittent claudication. Initially, he used to walk for 400 meters without any pain. But now, after walking 200 meters, he develops pain, okay? So definitely the distance, the claudication distance have been decreased. So it is progressive in nature. Pehle 400 meters chal sakta tha, now he can only walk up to 200 meters and then pain arises. So the claudication distance has been decreased. Pain was increased on lying down, okay? So as I told you, when the patient is when the patient starts walking and then if the patient has pain, then that is called as intermittent claudication. But beyond intermittent claudication, if usually the arterial, as we have discussed this in arterial disorders, right? In arterial obstruction, in gradual arterial obstruction, when there is a slowly progressive blockage in the artery, that is an gradual arterial obstruction. Usually due to the obstruction, the patient will have decreased blood supply to the distal part of the leg or the muscles, and definitely initially the patient will have pain only on walking. That is what is known as intermittent claudication. But usually in the later part, what will happen, the blood supply would be obstructed more, okay, and in this time what can happen, the blood supply to the nerves would also be impaired. And if the blood supply to the nerves is impaired, definitely the patient can have pain at any time. Not only on walking, the patient can even have rest pain. So here the patient is having pain even on lying down. That means it is a classical case of option B, rest pain. Okay, it is not a venous claudication, it is an arterial claudication. And usually patient starts with intermittent claudication, then further progresses to rest pain, then it further progresses. Rest pain is also known as cry of dying nerves, as we discussed, right? Then it further progresses to critical limb ischemia, and finally it leads to gangrene. Okay, so that all of that we have discussed. I also discussed with you about the ankle brachial pressure index, which is used. The investigation of choice for arterial obstruction is definitely a colored Doppler, right? All of this we have discussed, or duplex ultrasound, whatever it is. No issues with this, anybody? Sciatica is a nerve pain, okay, and it would be rest pain from the initial days itself. It would not be like the patient will have pain on walking initially. The patient will have pain anytime, okay, and here it was a classical case of arterial obstruction usually. Question number 153, a burns patient was brought to the emergency with involvement of the whole back, the gluteal region, and the posterior aspect of the neck. Which of the following is the preferred treatment option? So here, if there is a burns patient, as we have discussed, for first degree burns, definitely we do exposure only. Kuch nahi karna hota uske liye. Second degree burns, definitely we can do a burn dressing with ointments like silver sulfadiazine cream, or it can be mafenide acetate cream. Okay, any of those can be used. Whereas for third and fourth degree burns, as we know, here we definitely need to do debridement or cleaning of the wound. Okay, debridement is nothing but cleaning of the wound. Followed by that, we need to do skin grafting in the patient. Okay, because most of the area would have burned. So there, followed by that, we need to do skin grafting. And if it is a third degree burn, escar agar hai, to escarotomy bhi karenge. So here definitely, if the patient had so much of burn, usually the whole back, gluteal region, whereas posterior aspect of neck was involved, definitely the patient, first of all, please remember guys, here the patient will need resuscitation. First of all, I told you what is the immediate or next step in management. I told you, if whether the patient comes to you with bleeding, any type of bleeding, whether it is abruptio placentae, placenta previa, road traffic accident, hypovolemic shock, whatever it is, if the patient comes to you with bleeding, or if the patient comes to you after burns, usually, if there are extensive burns, the first thing to be done is definitely resuscitation. Followed by that, you need to go for debridement and allografting. Okay? So that is important. Allografting or autografting, whatever it is. Autografting can also be done. Okay, skin grafting is to be done. Debridement and excision of the burn skin, yes, that would be done, but that would be later. First, the important thing is resuscitation of the patient. Okay. And here, debridement, excision followed by resuscitation. No, resuscitation should be the first step usually. Okay. You need to save the patient first of all. You need to insert two wide IV bore cannulas, 18 gauge cannulas minimum. Which among the following methods is best for hair removal before surgery? So this was definitely a question which was just logical. I hope so. Definitely Dr. Vinayak would have covered in his sessions. Which among the following method is best for hair removal before surgery? Option E says hair removal by razor on evening before surgery. So usually nowadays, जो पहले करते थे ना, and evening before surgery, the patient was prepared for OT. Nowadays, it is not done. The hair removal is not done a day prior to surgery or an evening before surgery, because the chances of contamination of the surgical site will increase. Okay, so now it is not done usually a day before or an evening before. Rather, it is directly done on the OT table by the surgeon. Okay, usually. So hair removal with the use of cream also. Please remember, better than cream, definitely. Cream is the second best choice. The first best choice is definitely use of clippers nowadays. Clippers followed by cream, depilating cream, followed by usually your razors. Razors क्यों नहीं use करते? Because razors can give multiple cuts and that will increase the risk of infection in the patient or contamination. ठीक है? So therefore, razor on the OT table with razor is the third best choice. Second best is with the use of cream, and the first best is definitely on the OT table with the use of clippers. ठीक है? Nowadays, the best preferred choice is clippers. Question number 155. what advice will be given to the patient before laparoscopic surgery? So prior to a laparoscopic surgery or before any type of surgery, definitely we need to keep the patient nil per oral, that is NPO. Patient should not eat anything, or solid should not be taken 6 hours prior to surgery, 6 to 8 hours prior to surgery, whereas clear fluid should be taken 2 hours prior to surgery only. Okay, after that nothing is recommended. Okay, clear fluids are only recommended 2 hours prior to surgery before a laparoscopic one. Okay, so nil per oral before 6 to 8 hours the patient should take the meal, and clear fluids prior 2 hours of the surgery should be taken. So option A says eat full meal before surgery. No, that is not recommended. That will increase the risk of aspiration in the patient. Okay, then option B says drink plenty of water before surgery. No, again the same reason. Option C says NPO for 6 to 8 hours prior to surgery. Definitely this would have been the best answer. इसके अलावा और एक fourth option था, तो please let me know what was that. Okay, but most of them have given me this recall. So if these were the options, definitely option C, NPO for 6 to 8 hours prior to surgery would have been the best choice. Question number 155, which deficiency occurs after this surgery? What is the surgery? We have discussed this type of surgery. This is nothing but a ROX-NY. This is nothing but a ROX-NY gastric bypass surgery, or you can say a ROX-NY hepatico-jejunostomy. Okay? So it is a ROX-NY gastric bypass surgery. And as we have discussed, ROX-NY gastric bypass surgery is the best metabolic surgery. What do we mean by metabolic surgery or bariatric surgery? So metabolic or bariatric surgeries are usually done to decrease the weight. Okay, so metabolic or bariatric surgeries are used for morbid obesity, okay, to decrease weight in the patient. So definitely this is the best one, ROX-NY gastric bypass surgery or ROX-NY hepatico-jejunostomy. Okay, so here definitely please remember, let's rule it out one by one, which among the following deficiencies the patient will likely suffer from. So option D says vitamin D. So please remember guys, vitamin D definitely we take it from the diet. Okay, definitely. But apart from that, vitamin D is also synthesized in our own body. It is a atypical vitamin which is synthesized in our own body. It is synthesized in the skin, then liver, and finally in the kidney, right? So if there would not be so much deficiency of vitamin D as such, ठीक है ना, याद रखना. Second says calcium. So calcium, please remember, calcium is usually absorbed from the duodenum. Here the duodenum is intact. Okay, also from the proximal part of the jejunum. Okay, so if the duodenum is also not working, then also from proximal part of duodenum, from proximal part of jejunum, the calcium absorption can take place. Okay, so that is important. So here also calcium deficiency would not likely be seen in this patient. Then option B says protein malnutrition. There was a protein energy or protein calorie malnutrition was the option, I feel so. Okay, most of the people are saying it was protein calorie malnutrition. Definitely there should be protein calorie malnutrition in the patient. Okay, and that is the reason why we are doing actually a bariatric surgery to decrease the weight in this patient. So definitely this would not be a deficiency. Option A says copper. Yes, copper is definitely absorbed from the intestine, and if there you bypass the intestine directly, definitely there would be deficiency of copper in the patient. Okay? Moving further. Question number 156. Tumor cells secrete various hormones. Tumor cells secrete various hormones or chemicals which can affect various functions in the body. What is this phenomena called as? So this phenomena is nothing but a malignant cells secreting certain hormones or chemicals which will act like the normal hormones in the body. This is what is known as option A, paraneoplastic syndrome. Right, we have discussed about various paraneoplastic syndrome, and I told you definition also, it is important. The tumor cells or malignant cells secreting some other chemical or hormones which will resemble like a normal cell in the normal hormone in the body. For example, usually as we know in small cell carcinoma, it is the most common lung cancer associated with paraneoplastic syndrome. So in small cell carcinoma lung or oat cell carcinoma lung, here there is ectopic production of ADH, and therefore the patient can suffer from SIADH in this condition. So SIADH, which is due to small cell carcinoma lung, it is a paraneoplastic syndrome. Okay? No issues with this, anybody? So tumor lysis syndrome, I hope so. There was a we have discussed one question. The patient suffers from hyperuricemia after a tumor lysis syndrome due to destruction or damage of the tumor cells and the DNA of the tumor cells by the chemotherapeutic drugs. And for that, we gave the drug known as rasburicase. Okay? Next is question number 157. Dystrophic calcification is seen in which of the following? So dystrophic calcification is definitely, we have discussed D for D. That is, dystrophic calcification is usually seen in dead, dying or damaged tissues or degenerated tissues. Dead, dying, damaged or degenerated tissues may we will see dystrophic calcification. Whereas in normal living tissues, which type of calcification is seen? In normal living tissues, definitely we will see a metastatic calcification. We will see a metastatic calcification. No issues with this, anybody? So this we have discussed. Dystrophic calcification, dead, dying, damaged tissues. So here it is option B, atherosclerosis. We discussed atherosclerosis, Monkenberg sclerosis, okay, or some of our bodies in tumors, usually the PSM tumors we discussed. In all these conditions we discussed, there would be dystrophic calcification. Okay, most of you were confused with renal disease. So please remember, in renal disease, we will have metastatic calcification, guys, that we have discussed. In vitamin D intoxication, metastatic calcification. In milk alkali syndrome, metastatic. Whereas in parathyroid adenoma, we will not see even metastatic calcification. Please remember, I have given you a statement that parathyroid adenoma or hyperparathyroidism is the most common cause of metastatic calcification. It is the most common cause of metastatic calcification, right? That is important. The most common site for metastatic calcification, I told you, it is lungs. Okay? The most common cause of metastatic calcification is parathyroid adenoma or hyperparathyroidism, and the most common site being lungs. But I told you one statement that though hyperparathyroidism is the most common cause of metastatic calcification, parathyroid gland never calcifies. Yaad rakhna, parathyroid gland mein there is no calcium deposition as such. Okay? It is paired usually in metastatic calcification. So parathyroid adenoma mein to metastatic bhi nahi hota, dystrophic bhi nahi hota. Okay? Please remember this. And if it was talking about the tumor, so please remember the tumors we know where there are some of our bodies of calcified laminated structures, which are an example of dystrophic calcification. Those were papillary renal cancer, papillary carcinoma of thyroid, as for serous cyst adenoma of ovary, and for malignant mesothelioma or meningioma. Question number 158. A 20-year-old patient suffering from jaundice with high levels of unconjugated bilirubin. So definitely, if the patient is having jaundice, there would be increased levels of bilirubin. So the total bilirubin is increased, and there are two types of bilirubin, either the unconjugated or indirect bilirubin, or the conjugated or direct bilirubin. Here the examiner is saying it is high levels of unconjugated bilirubin. And unconjugated bilirubin, we know it is prior to conjugation from the liver. The cause is usually hemolytic anemia, or there can be some genetic causes, which we have discussed already. What would be the most probable diagnosis? So the answer here was not hemolytic anemia, rather there was some genetic syndromes which were given. And I gave you the mnemonic. If you have remembered the mnemonic, it would have been easier. I told you unconjugated, remember it as uncivilized, and conjugated, remember it as civilized. Okay, so uncivilized kaun hota hai? CG, that is, don't take it otherwise. Okay, unconjugated as CG. So Crigler-Najjar syndrome and Gilbert syndrome are two examples of unconjugated hyperbilirubinemia. Okay, so please remember hyperbilirubinemia, unconjugated hyperbilirubinemia ke two examples hai Crigler-Najjar syndrome type 1 and type 2 and Gilbert syndrome. And whereas conjugated, that is civilized. Civilized kaun hota? Doctors. Okay, so doctors, that is D for Dubin-Johnson syndrome and R for Rotor syndrome. D for Dubin-Johnson syndrome and R for Rotor syndrome. These two are examples of conjugated hyperbilirubinemia. Okay, yaad rakhna. With this, Dubin-Johnson and Rotor definitely will lead to elevated levels of conjugated bilirubin, right? So here it was the example that was Gilbert syndrome which was given. The question of Gilbert syndrome, even I discussed in test and discussion with all of you. Okay, na? Question number 159. Which among the following is the cause of macrocytic anemia? Macrocytic, we know if the mean cell volume is more than 100 femtoliters. Normal mean cell volume is 80 to 100 femtoliters. If the cell size or mean cell volume is more than 100 femtoliters, it is what is called as macrocytic anemia. And we discussed the mnemonic for macrocytic anemia, guys. Okay, I hope so. Over here, L usually stands for liver disease. L stands for liver diseases. Okay, that was the mnemonic we gave. LHMC, Lady Harding Medical College. Okay, so definitely liver disease is the cause of macrocytic anemia. Megaloblastic anemia, cytotoxic drug, all of these are also the other causes of macrocytic anemia in the patient. No issues with this, anybody? Iron deficiency, thalassemia, anemia of chronic disease. Some people are saying there was sideroblastic anemia instead of ACD. So whatever it was, sideroblastic anemia, all of these. Sita, we have the mnemonic. Okay, S for sideroblastic, I for iron deficiency, T for thalassemia, A for anemia of chronic disease. All of these are examples of microcytic hypochromic anemia, not macrocytic normochromic anemia. Okay, so I hope this was easier for all of you to rule out. A very easy question. And liver disease, there are multiple liver diseases like beta lipoproteinemia is also one of them, right? Question number 160 now. The pattern of inheritance with neural tube defects is. So neural tube defects, as we have discussed, kab hota hai neural tube defect? If the anterior or the cranial neuropore or the posterior or the caudal neuropore is not able to close properly. We know neural tube hoti hai, usse the neural structures usually develop. But usually this neural tube has two ends. One is the cranial end, second is the caudal end. This will obliterate or close. The cranial end closes by 25th day, caudal end closes by 28th day of intrauterine life. But if they do not close, they remain patent, then that can lead to neural tube defects in the patient, right? That we have discussed in anatomy embryology session. as well as multiple other times as well in pedia, in obs-gynae, everywhere. So here the patient is having neural tube defects. So definitely if the patient is having neural tube defects, I told you there would be high risk of neural tube defects in the pregnant female if she has a previous history of neural tube defect. Because definitely there is some genetic association in this. Okay, there is some genetic association or genetic mutations which are the cause of neural tube defect. First thing. Secondly, as we have discussed, that usually deficiency of folic acid is one of the leading causes of neural tube defects. So if the patient is on anti-epileptic drug therapy, definitely drugs like phenytoin will decrease the folic acid levels, and therefore that can cause neural tube defects in the fetus. Apart from that, dietary folic acid deficiency also in the female can lead to neural tube defects. Okay, so all of these are important causes. So there are multiple causes. There can be some genetic causes, there can be some dietary causes, there can be some pharmacological causes like anti-epileptic drugs. Okay, so all of these together contribute to neural tube defects. So it cannot be any other type of Mendelian inheritance. Rather, it is option B, multifactorial inheritance. Multifactorial inheritance we have studied for hypertension, diabetes, or any of the non-communicable diseases for that matter. Okay, so this was the easier one. Moving further, question number 161. An elderly patient presents with low backache and headache. His urinary examination reveals presence of Benz-Jones proteins. So we know Benz-Jones proteins are nothing but abnormal light chains of antibodies which are present in the urine. Okay? So which of the following is the most expected finding in his urine? So here, elderly patient, low backache, along with Benz-Jones proteins in urine, the diagnosis is straight away multiple myeloma. Okay? ये तो पता चल गया. Which of the following is the most expected finding is in urine? So as we know, multiple myeloma क्या होता है? It is a plasma cell malignancy or a plasma cell dyscrasia. What happens in this? Usually there is excessive proliferation of the plasma cells, and plasma cells are known to produce antibodies, right? So as we know, a normal antibody will have a heavy chain, okay, that is IgG, IgM, IgA, IgD, and IgE. Whereas it will have a light chain, and light chains are two types that we have discussed. Either it is a kappa chain or a lambda chain. Okay? The more common one is the kappa chain to be produced. Okay? So here the patient would not have overproduction of heavy chains. The defective plasma cells will have overproduction of these light chains of antibodies, and mainly the kappa chains are overproduced. So usually in the urine there is excretion of these kappa light chains. Okay, so here the answer was straightforward. It was option A. Kappa light chains are excreted in the urine of a patient of multiple myeloma. Okay, so that was a straightforward question. No, nothing to be discussed in that. Question number 162, which of the following is the grade of glioblastoma? We have discussed about glioblastoma multiforme, that was the previous name. So glioblastoma, usually it is a brain tumor. It is nothing but the malignant astrocytoma, right? Astrocytoma is the one which arises from the astrocyte or the supporting cells of the neurons. So astrocytoma ka most severe version or the one having the poorest prognosis is definitely glioblastoma. So itna bhi pata hai tumhe ki glioblastoma is the malignancy of the supporting cells, and it has the poor prognosis or the worst prognosis among all brain tumors. This we have discussed. So definitely the grade would have been grade 4, right? So this was easy, and Dr. Tarun would have also discussed in his sessions. Okay, as I have also repeated once or twice in my sessions ki glioblastoma is usually grade 4. Okay, grade 1 is usually your pilocytic astrocytoma. Okay, and likewise it progresses to grade 4. That is the most the malignant version of astrocytoma or the poorest prognosis, that is glioblastoma. Butterfly tumor, and we have even discussed about the histopathology feature, that is pseudopalisading or Garland necrosis is seen. All of that we have discussed. Question number 163. A 10-year-old child presents with skin rashes on the lower limbs. Sometimes they can even mention buttocks. Classical case सबको आता है, बहुत बार discuss कर चुके हैं. So a type of vasculitis, child presenting with skin rashes or purpuric rashes they will mention. Right, purpuric rashes on the lower limbs or the buttock. There is pain in the joints and there is lower abdominal pain. Pain in joints is what is called as arthralgia, right? Along with there is abdominal pain in this child. Sometimes they can even mention about hematuria in the patient or some other features. So which of the following is the most likely cause of manifestations in the patient? So definitely there's a small vessel vasculitis in a child, and the most common the most common type of vasculitis in child worldwide, as we know, it is HSP, Henoch-Schönlein purpura, whereas in India or in Asian population, it is Kawasaki disease. So here the diagnosis was easier. It was option B, Henoch-Schönlein purpura, which is characterized by purpuric rashes of skin mainly on the lower limbs or buttocks. The image had come earlier. I have shown it to you. And there are classical two other features of arthralgia and abdominal pain, cramping abdominal pain. Likely diagnosis is Henoch-Schönlein purpura. Kawasaki we have discussed. There should be more than 5 days of fever along with cream features, that is conjunctivitis, rash, edema and erythema of hand and feet. adenopathy, that is mainly unilateral cervical adenopathy, lymphadenopathy, and M for mucosal involvement, that is strawberry tongue. Okay. Alport syndrome is the most common cause of hereditary nephritis. There the patient will have hematuria. It is an example of nephritic syndrome. Okay. Along with ocular feature like anterior lenticonus or sensory neural hearing loss. Takayasu arteritis is more common in 50 to 60 year of age group, and it is known as a pulseless disease because there is narrowing of the left subclavian vein. So pulse is not felt usually in the left arm. That is what is the case of Takayasu arteritis. Okay? Moving further, 164. A patient who was a known case of diabetes mellitus now presents with hyperpigmentation of skin. Again, a discussed question multiple times. On examination, he was found to have micronodular cirrhosis with increased iron deposition. Okay? Which of the following is the most likely diagnosis? So I hope this was easy. A patient having pancreatic dysfunction, right? And therefore he develops diabetes mellitus along with hyperpigmentation of skin. And this hyperpigmentation is usually due to activation of the melanocytes. ये discuss किया था मैंने PYQ में तक discuss किया था. So definitely this hyperpigmentation is usually due to activation of the melanocytes, and that is what is known as the bronze pigmentation of skin. And the diagnosis becomes bronze diabetes or bronze diabetes mellitus. And this is due to a condition which is due to iron excess in the body. And this iron excess condition in the body is known as hemochromatosis. The answer here is straightforward. That is option C, hemochromatosis. As we know, there is excess of iron deposition in multiple organs of the body. The most common is definitely the liver. So therefore, the liver will suffer from micronodular cirrhosis. Along with that, if it activates the melanocytes, it will cause bronze pigmentation of skin. Along with that, if this excess of iron deposits in the pancreas, it will lead to dysfunction of pancreas, leading to decreased insulin secretion, causing diabetes mellitus in the patient, right? So bronze diabetes along with increased iron deposition, straight away go for hemochromatosis as the answer. Viral hepatitis, man, there was a question people are saying, I'm not sure about that. Please let me know. If there was a question, we have discussed that definitely. In acute viral hepatitis, the patient has apoptotic bodies. Okay, the hepatocytes will have pinkish appearance or eosinophilic appearance. And these apoptotic bodies are nothing but called as the Councilman bodies, discussed multiple times. Okay, that is called as the Councilman bodies. Alcoholic cirrhosis, there should have been history of alcohol intake in the patient. Apart from that, hyperpigmentation is not seen. Rather, jaundice is seen in the patient who is alcoholic. Okay, so that is the funda. Please remember this. Okay, no issues with this, anybody? So please remember. Moving further, Wilson's disease, there is excess deposition of copper inside the liver, and the second most common organ affected, it is definitely not the skin. It is not the pancreas. It is usually the descendants membrane of cornea, which leads to K-ring or sunflower cataract in the lens, or it is usually the basal ganglia, which leads to Parkinsonism-like features. Moving further, question number 165. The most abundant plasma protein, discussed multiple times. I used to tell you, the most abundant protein inside body is collagen, but the most abundant plasma protein, all of you knew the answer. It was straight away option B, albumin over here. Okay, so most abundant plasma protein. Even if we do a electrophoresis, as we know, this kind of a picture is seen. This is what is albumin. This is alpha globulin, beta 1 and beta 2 globulins, and this one is the gamma globulin. That is your antibodies. So the most abundant one on electrophoresis also, you can see this picture we have discussed. This is albumin. Okay, no issues with this, anybody? Question number 166. A 10-year-old child brought to the OPD with constant fatigue and abdominal pain. He also has falling grades at school and peripheral smear shows crescent-shaped RBCs. Which of the following is likely to improve condition of this child? So please remember, guys, this was a classical case. If they mention on peripheral blood smear, there are crescent-shaped RBCs or half-moon-shaped RBCs. These are nothing but sickle-shaped RBCs. Okay, and sickle RBCs are usually a feature of sickle cell anemia, which is an example of hemoglobinopathy or hemolytic anemia. A 10-year-old child with constant fatigue, okay, that is the classical weakness, fatigue, pallor are classical symptoms of anemia. Okay, उसमें कोई दिक्कत नहीं है. But the patient is also having abdominal pain, and we know if the patient is having abdominal pain or chest pain or swelling and pain at the fingertips, this is usually likely a feature of sickling crisis. Whenever these RBCs, they are of normal shape, biconcave shape when they are oxygenated. But once oxygen is removed from them, they turn into the sickle shaped or half moon shape, and these will get sticky now. So they will stick to each other and they will block the small capillaries. If they block the small capillaries which are supplying the intestine, then definitely the patient can have ischemic colitis or mesenteric ischemia, leading to abdominal pain in the patient, right? So apart from acute chest syndrome, dactylitis, autosplenectomy, the patient can even have abdominal pain due to ischemic mesenteric ischemia, right? So here the child is suffering from acute sickling episode in the patient. Okay, so what is the following treatment option which is likely to improve his condition? So people were saying urgent. Some people said that urgent transfusion was mentioned. So if urgent transfusion was mentioned, then definitely that would have been the best answer, because urgent transfusion will definitely help improve the condition of the child. Okay, immediately. So agar patient comes to you in sickling episode, याद रखना मैंने क्या बोला था, if the patient comes to you in sickling episode, definitely you need urgent transfusion. But if the patient comes to you before that, if the patient is having sickle cell anemia, for prevention of prophylaxis, the drug which is used, the drug of choice for prevention of prophylaxis of sickle cell anemia, is definitely hydroxyurea. ठीक है? So अगर urgent transfusion था option में, better mark it. अगर नहीं था, most of the people saying it was not there. So if it was not there, then definitely go with hydroxyurea as the best option. ठीक है? Definitely intravenous fluids would be started. Hydration is given to the patient. Okay, analgesics are given to the patient to decrease the pain, that is, give pain relief in the patient. But the patient will improve his condition only on giving either hydroxyurea, and the best one out of all is urgent transfusion. Okay, moving further. Question number 167. A patient was a known case of bronchial asthma and now presents with acute exacerbation of dyspnea or breathlessness and palpitations with a SpO2 of 88%. So SpO2 is dropping in the patient. Which among the following is not used in the immediate management? Not used. Okay, so the question was not used. So here the patient is a case of bronchial asthma presenting to you with acute episode of asthma in the emergency. So definitely some people were saying that leukotriene antagonist was not an option, rather it was oxygen as a separate option, and nebulization with salbutamol was a different option. Okay, so let's discuss it. Option A says nebulization with salbutamol or nebulization with oxygen. So definitely, even if we start nebulization with salbutamol, we give it oxygen-driven nebulization with salbutamol. ये मैंने discuss किया था, because oxygen is required to improve the hypoxemia in the patient, right? So oxygen-driven nebulization with salbutamol is given. So definitely, option A is the choice that we give in this patient. Option C says hydrocortisone. Definitely, we know, like the drug of choice for bronchial asthma, it is usually hydrocortisone or steroids, corticosteroids, right? Inhaled corticosteroids are given to the patient. Okay. And if the patient presents to you in acute episode or like severe exacerbation, definitely we will give IV steroids to the patient. So here we give IV hydrocortisone to the patient. Leukotriene antagonists are drugs like montelukast and zafilukast that can also be given in the patient. Okay, if that was not the option, definitely oxygen supplementation is definitely given in patients of acute asthma. But IV magnesium sulfate is not a treatment of choice which is given or preferred in cases of acute asthma usually. Okay, so yaad rakhna, IV magnesium sulfate, as I told you, it is a drug of choice for eclampsia, and it is also considered in cases of torsades de pointes, which is a type of polymorphic ventricular tachycardia. It can be given in cases of brittle asthma वगैरह, but not in cases of severe acute asthma. ठीक है, respiratory failure वगैरह में try कर सकते हो, not over here. Question number 168. A patient presents to the OPD with weakness and ataxia. There was history of one episode of unconsciousness. What is the most likely vitamin deficiency? So here the patient are saying the patient was mentioned as a chronic alcoholic. So अगर patient alcoholic या chronic alcoholic mention किया गया था, and now the patient is having ataxia, that is balance disturbances, along with weakness, or sometimes they can even mention you about confusion or ophthalmoplegia. So all of these we know. This is the classical features of Wernicke's encephalopathy, and Wernicke's encephalopathy or Korsakoff syndrome usually develops due to deficiency of vitamin B1, that is option D, thiamine. So option D, that is thiamine or vitamin B1, is the likely deficiency seen in chronic alcoholics. Okay? Riboflavin will lead to angular stomatitis, as I discussed yesterday. Angular stomatitis, geographic tongue, there would be glossitis, there would be cheilosis. We have discussed vitamins in great details. मैंने video upload कर रखी थी पूरी details में vitamins की, that you can check still on the Afmge YouTube channel. I've discussed vitamins in PSM, biochemistry. Everywhere I came across vitamins, I discussed all of that. Okay, so I don't think so there would have been any issue. Niacin deficiency leads to pellagra. We have discussed all the 6 Ds. Folic acid deficiency leads to megaloblastic anemia. Okay, apart from that, neural tube defects. Question number 169. Which of the following vitamin deficiency is most likely to cause tingling sensation and numbness? So tingling sensation and numbness usually in the hands and feet or usually in the extremities is likely a case of peripheral neuropathy. Here the patient is having peripheral neuropathy. And peripheral neuropathy, as we know, it is due to deficiency of 2 vitamins. It is either vitamin B12, which is also called as cobalamin, or it is vitamin B6, which is also known as pyridoxine. So some people are saying vitamin B12 was there in the option. If it was not there, definitely vitamin B6, that is pyridoxine, is one of the important causes of peripheral neuropathy. So here the answer would have been option D, pyridoxine. जो बोल रहे हैं ना folic acid. So please remember guys, folic acid leads to hematological manifestations, not neurological manifestations. Only neurological manifestation associated with folic acid is neural tube defect. It does not cause peripheral neuropathy. याद रखना. Okay, it is a combined deficiency of vitamin B12 and folic acid then which is causing neuropathy in the patient. It is not isolated folic acid deficiency. याद रखना हमेशा. ठीक है? So if not cobalamin in the option vitamin B12, then please go for pyridoxine of B6. It's a very common cause of vitamin deficiency. Very common cause of peripheral neuropathy in the patient. ठीक है? Moving further, question number 170. A tall obese patient with abdominal girth of 95 centimeter and fasting glucose of 110 milligrams per deciliter and was diagnosed with metabolic syndrome. So definitely if the patient is having morbid obesity and fasting glucose is also high, definitely the patient is having diabetes mellitus. So morbid obesity, diabetes mellitus, hypertension, all of these clumped together will lead to metabolic syndrome in the patient. Which among the following is most likely to be found in this patient? So now people are saying the option was increased triglycerides. It is a cause definitely, but it was not increased cholesterol या फिर LDL. Okay, so better look for the other options. Option A says increased uric acid and insulin. Maybe insulin can be decreased because there is morbid obesity, so there can be chances of insulin resistance. Metabolic syndrome में there are high chances of insulin resistance in the patient. ठीक है ना, याद रखना. There are high chances of insulin resistance, and therefore there would be elevated levels of insulin in the patient. ठीक है? So that can be seen definitely in the patient. Uric acid is not elevated usually in cases of metabolic syndrome. Gout is not a coexisting disease in this condition. Option D says increased blood sugar. Yes, definitely. If the patient is having diabetes, definitely there would be increased blood sugar in the patient. So increased serum calcium, no. Serum calcium levels would not be increased in this patient. Okay, yaad rakhna, please remember. Now we are left with option B and C, that is increased triglycerides and HDL. Triglycerides, LDL, total cholesterol, that would be increased. But HDL is a good cholesterol which is not increased in cases of metabolic syndrome, rather it is decreased. So here, if I need to choose the best option out of all, so by the rule of exclusion, I need to go with option C, that is increased blood pressure and insulin. So because in metabolic syndrome, usually the patient are likely to be having hypertension as well as a coexisting disease. So there can be chances of increased blood pressure and increased levels of insulin as well due to insulin resistance, which is there. Question number 171. If there was total cholesterol or LDL in the option, then option B would have been the best answer. But agar HDL tum log bol rahe ho, then option C would be a more likely answer to this question. ठीक है? Question number 171. A patient presented with respiratory distress and flushing on urinary examination, elevated levels of 5-HIAA. Okay, that is 5-hepatic aminodiacetic acid levels are elevated. Okay, what is the diagnosis? As I told you yesterday also, when I was discussing about pheochromocytoma, one question, there would be elevated levels of vanillyl mandelic acid in the urine in pheochromocytoma. But in cases of carcinoid syndrome, there would be elevated levels of 5-HIA, that is hepatic aminodiacetic acid in the urine as well as in the serum. So serum levels are elevated, therefore there is excretion of these 5-HIA in the urine as well. So serum as well as urine levels of 5-HIA are elevated in cases of carcinoid syndrome. ठीक है? Carcinoid syndrome में we know there is a paraneoplastic syndrome which is associated. Carcinoid syndrome is a neuroendocrine tumor, and these neuroendocrine tumor are known to secrete some other hormones. Okay, that is what is serotonin. So serotonin is secreted by the malignant cells of carcinoid tumors, and the serotonin will cause flushing, and it will cause vasodilation, and therefore it will cause flushing on the face or facial congestion. Apart from that, it will also cause bronchoconstriction, which will lead to respiratory distress in the patient. Okay? So here the patient is having carcinoid syndrome, due to which there is serotonin syndrome which is developed in the patient. And definitely if there is 5-HIA levels are elevated, definitely it is a classical case of carcinoid syndrome. Okay. Question number 172. A pregnant lady presents with a pigmentation over the face as shown. What is the condition? So here, definitely if a pregnant lady or a middle-aged lady presents with blackish or brownish pigmentation over the skin, guys, please remember it is a classical case of option A, chloasma, also termed as melasma, right? Or hyperpigmentation usually over the sun-exposed areas. It is due to the hormonal disturbances which are seen during pregnancy. And please remember, chloasma or melasma is commonly seen in the second trimester. ये question हमने discuss किया था. Chloasma or melasma I discussed in ops. It is second usually in the second trimester of pregnancy. Okay, that was the question we discussed. Apart from this, the other options, more likely, I think there would have been malar rash as well in the option to confuse most of you. Moving further, question number 173. A substance abuser was found lying unconscious on the roadside. On examination, pinpoint pupils were noted. What is the cause? I have discussed pinpoint pupils ke causes with all of you guys. I don't think so there would have been any issue with all of you. Okay, so OP poisoning was the mnemonic that I discussed for pinpoint pupils or meiosis in the patient, right? So O usually goes for OPC poisoning. O goes for organophosphate and carbamate poisoning, right? So OPC poisoning is one of the important causes. Second, O also goes for opioid toxicity or opioid intoxication, right? Opioid toxicity or opioid intoxication. P also goes for two conditions. First, P goes for pontine hemorrhages. If there is any bleeding at the level of pons, so pontine hemorrhages can lead to pinpoint pupils. And second, P usually goes for phenol poisoning or carbolic acid poisoning. That is also a cause of pinpoint pupils. So ये तो हमने discuss कर लिया था. I don't think so there would have been any issue. So definitely if the patient is having pinpoint pupil, the patient is lying unconscious and he is usually a substance abuser, the patient is more likely to be suffering from opioid toxicity or opioid intoxication. And the opioid that is commonly used for intoxication is nothing but option B, heroin. Okay, no issues with this. Some people are saying morphine was the option. So whatever it was, morphine or heroin, you can you could have answered it. Okay, easy. No issues with this, anybody? Moving further, question number 174. Necrolytic migratory erythema is a feature of. So necrolytic migratory erythema, this was a straight away one liner. This was a feature of option C, glucagonoma. Okay, this is a neuroendocrine tumor which is usually present in the alpha cells of the pancreas. That is what is called as glucagonoma. And here a skin manifestation is seen which is known as necrolytic migratory erythema. Okay, insulinoma is the most common type of pancreatic tumor. In insulinoma, it arises from the beta cells of the isolates of Langerhans of the pancreas. Okay? Moving further, question number 175. A 2-year-old boy reported with complaints of fever and cough for 2 days with chest indrawing and his respiratory rate is 38 per minute. What is the next step? So I discussed you, if a child presents to you with fever and cough, the first thing that you will actually think of is definitely pneumonia. Okay, if the child presents to you with fever and cough, the first thing comes to your mind is pneumonia, right? And in pneumonia, we need to look for, apart from fever and cough, the child can also have dyspnea or respiratory distress, or the child will have tachypnea, that is increased or rapid respiratory rate. So usually we have discussed, if the child is less than 2 months, the tachypnea would be considered if the respiratory rate is more than 60 breaths per minute. Okay, if the child is between 2 months to 1 year, then definitely tachypnea is considered if the breathing rate is more than 50 breaths per minute. Whereas if the child is between 1 year to 5 years, definitely tachypnea is considered when the breathing rate is more than, or respiratory rate is more than 40 breaths per minute. Here the child is having 38 per minute and the child's age is usually 2 years. So child is between 1 year to 5 years and the breathing rate should, or the respiratory rate should have been more than 40 breaths per minute to diagnose it as tachypnea. So the child is not having tachypnea, but other features of pneumonia are present like fever and cough for 2 days. Along with that, there is chest indrawing. So most of the faculties are saying that chest indrawing is a feature of severe pneumonia. Pehle tha. Guys, please remember, you can watch other faculties videos also. In PSM, you can look for chest indrawing was a previous feature for severe pneumonia. According to the recent IMNCI guidelines, right? Chest indrawing has been removed from the severe pneumonia and it is only a feature of pneumonia, guys. Please remember, chest indrawing agar present hai na, chest indrawing along with tachypnea, it is a feature of pneumonia, not severe pneumonia. Severe pneumonia or very severe disease would be said if the child is having other features also, right? The signs of the general danger signs. If the child is unconscious, the child is vomiting continuously, okay? If the child is having, the child is lethargic, unconscious, vomiting, seizures, convulsions. So these are the general danger signs. Or the child is avoiding feed, not taking feed. These are the general danger signs. Agar wo present hai, then definitely I can diagnose the child as severe pneumonia or very severe disease, but not just based on chest indrawing. If there is only chest indrawing, I will go with pneumonia as the choice, guys. Most of the faculties you can ask, like PSM faculties, they have, according to IMNCI, according to recent ones, they diagnose it as pneumonia. And here the patient is having pneumonia, so option B, pneumonia and antibiotics would have been the option. हर एक बार severe pneumonia नहीं होता है guys बच्चों में, ठीक है ना? हर एक बार question में severe pneumonia ये very severe disease पे नहीं देंगे, right? So in question there was one PYQ was also no pneumonia and home-based care. So this time they gave pneumonia and antibiotics, okay? And if it would have been severe pneumonia, बहुत ज़्यादा insist कर रहे हो कि वो severe pneumonia ही था and very severe disease, the pink colored management, then severe pneumonia, antibiotics and referral. The first dose of antibiotics is given and referral to a higher center is done accordingly then. Question number 176. A patient underwent a surgical procedure for a pathology wherein preoperatively the left lung was collapsed. Here you can see almost the left lung is collapsed, okay, as shown in the image. What is the likely diagnosis? So here if I just zoom in the x-ray, What can you see on this chest X-ray? You can see, usually if I can just use this is the lung which is collapsed, and the remaining part here you can see almost there is increased blackening. The size of the left lung is usually, the size of the left thoracic cavity is increased. Why? Because there is hyperinflation, there is flattening of the diaphragm. So there is if there is increased blackening, definitely there is accumulation of air. Or agar air accumulated hai, so please remember there would be increased blackening. Along with this, if you can compare the right and left side, as I discussed yesterday also. So on right side, you can see the bronchovascular markings which are seen. Okay, the whitish lines which are seen. These are the bronchus and vessels which are seen. But on left side, you can see no bronchovascular markings. Why? Because there is presence of air throughout the pleural cavity. Okay? So if there is presence of air in the pleural cavity, collapsed lung, along with absent bronchovascular markings, and the trachea is shifted to the contralateral side, along with the flattening of diaphragm, and this classical sign known as the deep sulcus sign. So this is the classical feature of pneumothorax. Okay, no issues with this. This is the classical feature of pneumothorax. Okay? So which sided pneumothorax the patient is having? Definitely the patient is having a left-sided pneumothorax. As I told you on X-ray, CT, MRI, hamara right matlab patient ka left matlab hamara right. Okay, that is what is this the funda. So here the patient is having left pneumothorax. Hydropneumothorax I discussed, there would be a classical horizontal line which is seen. Okay, separation which is seen. Pneumonia, there would be consolidation of whitish opacity. यहाँ पे whitish नहीं blackish दिख रहा है सब कुछ. Question number 1, and the subcutaneous tissue, right? And it will have better outcomes. But a partial thickness or a split skin graft will not have better cosmetic outcomes, but it can be easily stretched and it can cover a large area of skin. So अगर extensive damage है, तो बहुत ज़्यादा skin grafting करनी है, तो you will prefer a partial thickness or a split skin graft. And it will only contain of option B, epidermis and partial dermis. Okay? That would have been the best answer. And it is usually taken, as we know, a partial thickness graft is usually taken with a Humvee's knife. Okay? Nowadays, for partial or full thickness graft, we also have the electric dermatome, but usually we take it with the Humvee's knife or the Wolfie's blade. So Wolfie's blade is used for a full thickness graft. Humvee's knife is used for a partial thickness or a split skin graft. Okay? Moving further, question number 178. A child presents with bilious vomiting. Okay, bilious vomiting, that means a bile mixed vomiting. Or agar bilious vomiting, that means the obstruction is somewhere at the level of the intestine, whether it is at the level of duodenum or the jejunum, or maybe in the ileum as well. So therefore, the child is presenting to you with bilious vomiting. What is the most appropriate test to diagnose the condition in this child? So I'm not sure if ultrasound abdomen was the option. Definitely ultrasound is the first line management, first line investigation that we do. If they ask you about contrast studies, definitely for contrast studies, you can go with barium meal follow through. But if they ask you the most appropriate test or the best test out of all, definitely you need to go for option C, CECG abdomen for intestinal obstruction. Any kind of intestinal obstruction, the best test that needs to be done is CECG abdomen in the patient. Okay? Yaad rakhna. Moving further, question number 179. A 1.5-year-old child having problem with urination for the last 3 months, and you have introduced a contrast from the urethra to visualize and assess the tract as shown in the image. So here you can see the urinary tract. It has been, the dye has been injected from the urethra and it is traveling backwards into the urethra and then into the urinary bladder, right? So what is the investigation called as? Option A is micturating cystourethrogram. I told you MCU or micturating cystourethrogram is the investigation of choice for vesico-ureteric reflux or for posterior urethral valve in a male child. Okay? But over there, you inject a dye directly into the urinary bladder, first thing. And second, the X-ray is usually taken, or the serial X-rays are taken when the child or the patient is urinating. Here, the child is not urinating. Rather, the dye is traveling backwards and then you take an X-ray. So it cannot be a MCU or micturating cystourethrogram. Okay, here you cannot visualize the bladder also properly. Next says, option D says anterograde pyelogram or retrograde pyelogram. Yaad rakhna, pyelogram is to visualize. It is the contrast study done to visualize the renal pelvis or the ureters. Okay, unke liye jo karte hain, that is what is pyelogram or pyelography. Okay, so we have discussed about IVP or IVU. That is the same thing. I have discussed that there can be antigrade pyelography or a retrograde pyelography, or antigrade or retrograde IVP or IVU. Okay, when the dye is actually injected into the kidneys. Okay, so from there, if the dye is injected in kidneys, it is usually antigrade. If it is injected in the ureter, it is retrograde. Okay. So both of them are definitely not the options because kidney and pelvis are not seen over here. It is a urethra which is visualized. So definitely the straight away answer is option B, retrograde urethrogram. Retrograde Q because the dye is injected in a retrograde fashion. Moving further, question number 180 and the last question for today. A patient with irregular margins of the narrow urinary bladder with organism found on around the ureteric orifice. What is the cause? So So if a patient is having irregular margins of the narrow urinary bladder, so urinary bladder is usually narrowed down, ठीक है, तो shrinkage हो गया है, along with irregular margins दिख रहे हैं, and the organism is found around the ureteric orifice. So I don't think so. Even if you had this, it would have been easier, because we have discussed this image. Irregular margins of the urinary bladder is seen due to which infection? Definitely it is seen due to bladder TB or bladder tuberculosis, where the bladder will have a thimble appearance, or a thimble bladder is usually seen. Okay, so thimble bladder is a classical feature of bladder TB. So here the answer would have been option C, tuberculosis of urinary bladder is the answer over here. Schistosomiasis, here the patient will likely develop squamous cell carcinoma of urinary bladder. Okay, not narrowing of the ureteric orifice or irregular margins, or not any narrow urinary bladder, rather there would be a mass in the urinary bladder. Okay, transitional bladder cancer, again a mass would be present, not narrowing or irregular margins as such. So thank you so much. I hope I have discussed 180 questions till now. I'm not sure if I'll be getting more questions. So at least these many questions I've discussed. And I hope all of you have answered most of the questions right. All the very best for your results, guys. And I hope all of you really do well in the examination this time. And I see all your smiling faces. So let's meet in Delhi for sure after your results. Until then, goodbye, good luck. And yeah, let's meet soon. Thank you so much.